Good morning. My name is Virginia Schobel, and I'm the neurology franchise head here at Spherix Global Insights. I am pleased to have Dr. Story, Dr. Bilik, and Dr. Gottschalk here with me today. Dr. Helen Story is a family practitioner in Denver, Colorado, and an assistant clinical professor of family medicine at the University of Colorado. Dr. Ilya Bilik is an internist in Brooklyn, New York, and an assistant clinical professor of internal medicine at New York University Grossman School of Medicine. Dr. Christopher Gottschalk is a migraine specialist in New Haven, Connecticut, and an assistant professor of clinical neurology at Yale School of Medicine, chief of the General Neurology Division, and director of the Yale Headache and Facial Pain Center. Thank you all for joining me today. As Spherix, we have been trending the evolving migraine treatment patterns over the past 3 years based upon data from both our physician-reported surveys and patient chart reviews. The CGRP class of migraine therapies, which first entered the US market in 2018 with the launch of Aimovig, and then most recently with the 2020 approval of Vyepti, has had a huge impact on the way migraine is being treated. The launch of the GPads, or the oral CGRP receptor antagonists, in early 2020 coincided with the start of the COVID-19 pandemic, and we all know how much that has impacted our lives over the past year plus. But especially with the resulting disruption in medical care. So with those GPad launches, we also had the COVID-19 impact on the care of the patients. So we have seen some really interesting interplay between the different available CGRP options. But for today, instead of talking about our data in great detail, we really want to focus on our physicians' clinical experiences with these different brands and how they may differ between the specialists and the primary care segment of the market. So I will kick it off with a question and let the three of you really discuss between yourselves, but really kind of looking back, how has your prescribing of the subcutaneous CGRP monoclonal antibodies, so Aimovig, Ajovy, and Emgality, changed over time? Would you say that you're prescribing more or less new prescriptions of these agents now compared to at the start of 2020 or really pre-COVID? And I'll just kind of, in terms of any changes, would you say it's more because of COVID or more because of the GPAD launches or even other possible drivers of the change? And I will now leave it up to you guys.
So I would like to start by tacking on a couple of questions just so I have a better idea of what the landscape of your practices is like. So what percent of your current practice would you say is treating migraine? And then of your migraine patients, roughly speaking, what percentage of those are low to medium frequency episodic migraine and what percent are chronic migraine? So either one of you start there.
I'll just go ahead if I may. My practice, I have myself, 2 other docs, and 4 PAs. And we're a suburban family practice, broad spectrum. We're in a couple of the CMS quality improvement projects, where we're tracked rather closely on hospitalizations and ER visits. So we make a great effort to keep people out of the ER and out of the hospital as much as possible. And I would say, since the beginning of the COVID epidemic, we've implemented a lot of telehealth, which has been helpful for migraine management, just because, we didn't have to necessarily bring those patients into the office.
That's a really good point.
Yeah, and definitely the Aimovig has gained in popularity over the last year or two, since it came out. Although there's been a lot of hoop jumping that we've had to do just to get those drugs approved for people with recurrent or chronic migraines. I do believe from our stats that our ER visits have gone down substantially.
Because of the availability of the monoclonals, you mean?
Yeah. And also, I think there's part of it is just that more people were working from home during that period and getting more sleep, which, as we all know, is such a big factor in migraine management.
Absolutely. All right. So because you do family practice, you're treating adolescents all the way through geriatrics. And I'm interested still in sort of roughly speaking, of all the patients you or your group sees, what percentage of your patients are you treating for migraine? Granted, we know what percentage of them have migraine, but would you say that you're actually prescribing migraine in 20% of those patients, more or less?
Probably more than that, because we generally refer off to neurology if we think they need Botox, or, if we can't get them to a functional status with the drugs and interventions that we have available.
Okay. And would you say of the migraine that you're treating that it's, half episodic and half chronic, or more tilted towards chronic, or what does that look like?
Probably more tilted towards episodic, just because we have a fairly well-insured and functional working population.
Super.
Yeah, we have maybe 5% of our patients who are Medicaid, and some of those are just chronically disabled by various conditions.
Right. Super. Okay. Well, that's really helpful. Dr. Bilik.
First of all, it's a pleasure to meet everyone, and thank you for the opportunity to listen to the opinion of the national expert in headache, like yourself, Dr. Gottschalk.
Okay.
I think it's wonderful. And Virginia, thank you for the opportunity. I don't consider myself headache specialist, and not even close to being an expert, but I see a fair amount of patients with headaches. And actually, I remember, being 12 or 13 years old and reading Mikhail Bulgakov, Master of Margarita, for the first time, and description of this agonizing, terrible headaches which Pontius Pilatus had while interacting with, his prisoners, and this vivid, example of the headache, it actually changed my life somewhat. I realized how people are suffering. I do see a significant amount of headaches. I think that patients with a headache substantially, like everything else, there was a beginning of a COVID pandemic. Actually, the amount of patients went down significantly because people were concentrating on something else. On the peak of epidemic, I probably seen 50% of patients with COVID. I run urban faculty practice. I used to be in private practice for 25 years. And transitioned to the NYU faculty practice for the last couple of years. But I still maintain sort of like a private practice environment because it's an urban center. We have plenty of specialists, neurologists, and I see mostly two kinds of patients, either patients who I diagnose with a migraine, and then I usually treat them for acute episodes if they don't transition to the chronic migraine. Or I see patients who with established diagnosis who were already seen by neurologists, and I continue treatment in conjunction with neurologist treatment. In both situations, I rarely do prescribe CGRP antibodies. With the invent of the antagonists, it's a different ballgame altogether. But antibodies are mostly it's a neurology prerogative in my practice.
Very helpful. So you don't typically initiate monoclonal antibodies for migraine, but
No.
will you ever take over the prescribing of them once a neurologist?
Rarely, very rarely. Most of the time, 99% of the time, if a patient of mine is being treated by neurologist for the chronic migraine, is continuing to receive treatment by neurologist. Only when there is some sort of transition or unavailability of the specialist, rarely I do prescribe it.
Okay. That's great. So that helps me sort of get a sense of how different these landscapes are, which is significant, and I love that. So a couple of thought-provoking things you said, Dr. Story. So I got you mentioned something about ER visits going down. So your sense is that since the introduction of at least the monoclonal CGRP therapies, maybe also since the oral agents, the GPads, your impression is that the likelihood that your migraine patients end up in an ER is lower, which I completely agree with in my own practice. Dr. Bilik, do you have a similar impression? Do you think it's made a difference in terms of how often patients get into trouble?
Not in my experience. In my experience, it's a consistently special kind of the patients, mostly young women who come with debilitating symptoms, and they just disappear for the time being of peak of epidemic because of everything else. But at this time they're coming back more or less the same. I don't see much difference. I think the companies have made a very good job by advertising the new type of the therapy. So most of the patients of mine who suffer from migraine, they do know about the new types of therapy, GPads, and they sometimes even ask me to prescribe it.
Sure.
But I don't see any variation, and especially I don't see any decreased number of patients.
Okay. And then,
as a matter of fact, I'm sorry. As a matter of fact, there are a lot of headaches associated with COVID.
Sure.
But it's not a migraine type.
Right. That's a still to be determined what that is and what to do about it.
Right.
And then, Dr. Story, you also, I think you said that Aimovig is probably the most commonly prescribed in your practice, and I'm wondering whether that's increased from the year before that, so from 2019 to 20, or do you have the sense that that's gone up, or in what other way has the breakdown of the different products changed in the last year?
I think all of the providers in my group are getting more comfortable with the antibodies, and just to share, 3 of our 7 providers have migraines themselves.
Helps a lot.
Yeah, and both of them are on Aimovig, which is, they've found helpful. I've noticed just as looking at the schedule and everything, there's not as much of our providers and staff calling in sick with headaches.
And then I think you also said that you will refer patients to neurology for, say, Botox if treatments that you've tried haven't worked adequately. So my impression from that is that you will perhaps now try a monoclonal therapy as a preventive option, 1 or 2 of them, and if that isn't doing it, then might refer to neurology for Botox. Is that something like what happens, at least sometimes?
Yeah, and with me being here in Denver, it's, there's kind of a shortage of specialists in some fields, especially neurology and psychiatry. So we have to kind of carry the ball a little further than we might if there were more available consults.
Absolutely.
UC Health has a great migraine clinic that we can use for people that are just having a big struggle, but we're kind of expected to have at least tried the simple stuff before we refer in.
It makes perfect sense. So I will tell you for myself, the main shift from, say, 2018 or even 2019 has been more frequent prescription of Emgality than Aimovig, and that is a couple of things. It was already moving in that direction, mostly based on payer preference, that in our state at least, it was increasingly true that the formularies were prioritizing Emgality over Aimovig. And then with the gradual accumulation of potential side effects in the package insert, first constipation, then more severe constipation, and now hypertension, there has clearly been a shift towards using that as a second-line drug. And I find more and more patients, certainly it's true for me at Yale, that I treat a fair number of clinicians, physicians, nurses, whatever, and many of them are aware of these issues. So they will often bring that, that up with me. But it's certainly true. And then the other big shift is the introduction of Vyepti. So I have certainly been transitioning more of my patients who were already on monoclonals to Vyepti when either their response wasn't really great or they simply were excited about the possibility of having a quarterly infusion instead of having monthly injections, et cetera. So those two things have definitely made a difference in terms of what's going on. The frustration there for me is that it's true for the moment, and I can only guess when it's going to change, that I can't typically prescribe Vyepti as the first monoclonal therapy. I would very much like to do that for the majority of my patients, quite frankly, because I think it's a great paradigm. You come into the office every quarter, you get a treatment. We know exactly what your compliance is and what your responses are. But most insurers are requiring the failure of 2 of the other agents, if not all of them, and sometimes Botox as well. So that is something I hope over time we'll see some change, perhaps with more data from us.
Is Vyepti a brand that either of you are aware of from the PCP segment?
Yes, but we haven't prescribed it. My barrier is that we're an outpatient only practice, and so I can't use the infusion center at the hospital because I don't have admitting privileges.
Interesting.
Yeah.
So you must have patients in your practice, though, who are treated with rheumatological agents, or other autoimmune stuff. Do they all get seen by specialists who then refer for infusions that way?
Yeah, or who do infusions in their office.
Okay. So that's a niche that needs to be filled by a neurologist or somebody else.
Yeah, like for the MS patients, anything that needs to be done for them is done either in the neurologist's office or the hospital infusion center.
Okay. And Dr. Bilik, have you seen much Vyepti?
Not really. No, we do do infusions in the office of certain kind, IV fluids, sometimes antibiotics. But again, we don't have shortage of specialists of any kind. There are plenty of specialists of every subspecialty, not just neurologists, but headache neurology, and even special kind of headache neurology. So, it's most of the patients do get referred.
Super. Okay.
For treatment.
And then something else you led into, Dr. Bilik, that I'd love to hear more about. So you now have some number of patients in your practices who are on monoclonal CGRP therapies. And what are your thoughts and feelings about prescribing the oral agents, the GPads, for those patients? Do you do that?
Yes, of course, I do it all the time. I see absolutely no problems in that. And preventive therapy is supposed to be preventive therapy, but it sometimes fails. And I don't see, at least in what I know, there is no contraindication.
Agreed. And do you have the sense that their responses are any different when they're on the monoclonal therapies as opposed to the patients who aren't on those therapies?
I'm not sure. I think that they flare ups, of course, not as often as the patients without any preventive therapy. But in terms of the response, I don't see. If we're talking about using GPads for the prevention, that's a different story. But for monoclonal antibody, I'm not aware of any direction.
Yeah, no, it's
on another.
The jury's out on that one, but it seems the little bit of data we have says there's at least no clear difference, which is reassuring. How about you, Dr. Story? Where are you on that program?
We tend to stick to the more traditional things for our women of childbearing age, just because the data, we don't really know about the safety data, the GPads and the antibodies. Yeah, hopefully there'll be more information forthcoming as they get further down the line.
Yep. So, but in the patients who are already on a monoclonal, are you or your group comfortable with prescribing the GPads as well? Is there any issue there for you?
No, not at all.
Okay.
I will
Good.
say we haven't used a lot of Rayvow because most people want to be functional. They don't want to have to park themselves for 8 hours.
I totally agree. And I have to say, every time I see a new publication come out about lasmiditan and the fact that it's really effective, I mean, the data are actually terrific. And the more ways they look at it, the better it looks. I just cringe because I don't really use it either for the same reason. It's very difficult to say to a patient, I want to give you a treatment that will restore function, sort of. He's not allowed to do anything.
Can I just ask, with using a GPAD concomitantly in a patient who is on a monoclonal for prevention, have you run into any issues with getting that GPAD approved by payers, having that dual CGRP treatment?
Not so much the dual CGRP, but just the jumping through the hoops to prove that they failed the triptans or they failed the single molecule therapies.
So there really is not support at this time for using GPads as, let's say, for a naive, a newly diagnosed patient as their first acute treatment from the payer point of view.
Not so much yet.
Yeah.
And so that's an important topic too. So I am amazed that it takes so much work to get approval, for example, for a GPAD in a 60-year-old with coronary artery disease or a history of stroke. I mean, that should immediately mean that patient is first-line GPAD therapy, but I think the insurance companies are just not that savvy yet. They're just taking a hard line of fail the old stuff and move on, and that's all there is to it. I don't know if your experience is any different, but
about the same. We have to put in a prior auth saying this person has had a stroke and is not a candidate for triptans.
But at least they'll agree if you make that effort.
Yeah.
So
those have gone through.
Is that your experience too, Dr. Bilik, that they'll at least...
In my experience, it's much more difficult and labor filled. But we found the niche. We use specialty pharmacies. Specialty pharmacies get approval by themselves, and they know what to do. And 90% of the time, it saves us a lot of efforts. And because we have a lot of resources, including several specialty pharmacies in the neighborhood, it's convenient for the patients and convenient for us. As a matter of fact, representatives of the companies sometimes come with the cards for specialty pharmacy together with the samples. So
sure.
It's quite easy, and so far it's working. I'm afraid to hope for the future, but who knows? Now it's working. Yeah,
it's working for now. It's good news. Yeah. Super.
Can I just ask also, I mean, with the COVID-19 pandemic, and Dr. Story, I definitely heard from you a lot more virtual care. Dr. Bilik, I'm not sure if that's something that you also transitioned to. I think almost everyone did during that time. Was it at all more difficult to prescribe the CGRP monoclonal antibodies? Did you find yourself reverting at all to the small molecules for preventive care during that time due to ease of prescribing through those channels, or was there any impact on the viable treatment options when talking to a patient that needed something new or was newly diagnosed?
That's a story? Oh, you want me to answer? Okay. So 90% of the time, virtual video visits were about COVID. If we did not close the office for one day, we were working through the pandemic, and office was open for patients who did not have fever or symptoms of upper respiratory infection. So I practically seen the same amount of patients in the office with different kind of problems, but as I mentioned, 90% of virtual visits were about the COVID. Okay. In terms of the prescribing pattern, I think the only difference was the fact that I couldn't supply my patients with samples. But other than that, I did not find myself prescribing more single molecule medications. It was about the same pattern.
And Dr. Story?
We also were open, but a lot of people were afraid to come in. So about the same. The drug reps still haven't come back into the office other than to drop off samples.
But it sounds like you didn't find that the pandemic itself caused you to shift away from monoclonals or move back towards the old oral agents much.
No.
Okay.
Yeah, it was interesting because in our data, that we've been trending now for, I think we have like 12 quarters worth of data. We did see an interesting uptick in reported share of topiramate at that time, where the CGRPs pretty much stayed stable. And so one of our hypotheses were that it may have been easier or more comfortable to go back to that small molecule with that they have so much clinical experience with during that time. And we just saw with the most recent data that it appears like maybe it is again beginning to drop off, because obviously when the CGRP monoclonal antibodies first prescribed, topiramate was really where the switches were coming, or patients were discontinuing it with the efficacy of the monoclonal antibodies. And so it looks like maybe it will be a temporary perception of greater prescribing of topiramate, but I was just interested to see if that was your personal experience. Dr. Gottschalk, do you have any opinions on that from your point of view? Was there in your practice or with your colleagues any kind of shift back to maybe using topiramate? Yeah. No,
I mean, the main difference was that the introduction of Vyepti shifted some of our CGRP prescribing, but I certainly don't have the sense from certainly my practice or what I've heard people talk about that there's been any move back in that direction.
Yeah.
And then just on that topic of comparing monoclonal therapies to the old oral daily agents, certainly one of the reasons I'm so excited about the CGRPs is that they're so convenient for patients and relatively low in side effects, and that their compliance rates have been terrific. That I've prescribed these drugs now for 3 years. I have almost no patients who have simply forgotten or stopped taking it. They might discontinue for side effects or lack of efficacy, but I don't have people who just gave up and told me months later that they didn't like it, which I was used to hearing every day with topiramate and beta blockers and tricyclics. Do you have a similar experience that compliance with CGRP therapies is higher than the previous agents?
I would say so, because what we're aiming at with migraine treatment is functionality. So, people who are on topiramate tend to feel a little less sharp and sparkly than they do without it. So for them, it's kind of a trade-off. And people may be willing to accept a certain number of acute headaches per month in order to not have the dullness.
Well said.
Yeah. And
I agree. I think this relates to the effectiveness of the drug. If it's effective and safe, it has a small amount of side effect, and it's so pinpointedly directed on the pathophysiology of the migraine. People are compliant because it's working and it's safe and it's effective.
I would love to kind of move the conversation on to talk about some recent, exciting news that occurred just last week on Thursday. Biohaven, which markets Nurtec ODT, their GPAN, one of the two GPANs, the other one being AbbVie or legacy Allergan's Ubrelvy. But for Biohaven, they just got approval, the label expansion for Neurotech ODT. It was initially approved back in February 2020 for the acute treatment of migraine, and they just received approval for the expansion of the label to also cover the preventive treatment of patients with episodic migraine. So with this, the product becomes the first CGRP therapy to offer kind of that dual treatment goal coverage all in one product. So I'm interested to know from your points of view, you know, what are your thoughts on this? Does this constitute a true paradigm shift in your opinion? How, if at all, is it going to change your use of the drug? Will you start to see it more as a preventive, or are you going to just see it as a migraine treatment product without, pigeonholing it to acute or preventive? And then, of course, as part of that, just interested to hear what your current use of Nurtec was prior, and then how you see that evolving.
Go to it.
And I'll let Dr. Gottschalk, do most of the questions.
So,
well, it is exciting to have. Oh, go ahead.
No, that's what I was going to say. Go, please jump in.
Yeah, it's going to be great to have another option. How much we prescribe it will kind of depend on how much trouble we have with the pharmacy benefit managers. So,
Right.
Which is a contracting issue for the company.
Right. Yeah, that's certainly the big hurdle. But if we put that aside for a moment, this idea that there's now the option to prescribe a single drug for patients with migraine, saying you can take this every other day or so as a prevention, and then take an extra dose for acutely if you haven't taken that one that day as an acute therapy. Great model. Does that sound like something that you would start to use as a sort of first line treatment for new patients, or does that sound too esoteric, or how does that sit with you?
I think it would be very popular with the patients, given that the copays for these things are still kind of up there.
Right. Yeah, and hopefully there'll be some access to that, at least initially, that will make that more bearable. How about you, Dr. Bilik?
Yeah, I agree. I think it's a great news. In many instances, you don't think that you can use this, the same medication for prevention, and FDA approval means a lot in prescribing, for prescriber and for the patient. It give you confidence and give the patient confidence to try it. And I think it streamlines the whole process, because if you're already approved for the acute treatment, it's easier just to expand it for prevention, hopefully. I think it's a good news for the patients, because if they've experienced relief with acute treatment, they will have more confidence in using medication for the prevention. And overall, I think it's a good news.
Dr. Bilik, would you want your patients to have initial experience with the product as an acute therapy before considering them as a candidate for preventive?
Yes, absolutely. I think it's very appropriate. If somebody, again, my patients are they coming in two different categories. Somebody who I diagnosed with a migraine headache, and I would definitely ask them to try it as acute treatment first. And somebody who had been seen by neurologists for the last 10 years and already Aimovig and something else, that would be difficult to try to persuade to try something new, I think, if they are stable. But if they are not, again, you start as acute treatment, and if it's efficacious, then you can expand for the prevention, hopefully.
How about you, Dr. Story?
I think depending on the whole prior auth process, it would be a great new start drug. Because it is a bit of a hard sell to talk people into any kind of injections.
Mm-hmm. Mm-hmm. Yes.
Although, with any kind of treatment, since migraines tend to run in families, people come in and say, this worked for my sister. Can I try it for me? So as it gets more market share, you'll probably see more people being interested in having the same treatment.
So if that was ideally the patient's first preventive therapy, what products do you see Nurtec as a preventive therapy being most likely to displace? In terms of who would that, what product would that patient have started if Nurtec hadn't been available? Would it have been a small molecule? Would it have been a CGRP, monoclonal? How do you think that expansion of use is going to impact the existing market right now?
I think that it will gain market share. Like I said, a lot of people aren't happy with the small molecules because of the side effects. And as far as getting approval through the PBMs, it might be helpful just to have some data on absenteeism, presenteeism, cognitive function.
Good for you.
Help. Yeah.
Absolutely. And so, but given that you and your group are already in the practice of prescribing monoclonals for migraine patients yourselves, do you envision Nurtec replacing some of those initial prescriptions for prevention since it's available?
Yeah, absolutely.
And Dr. Bilik, I guess we'll see what the community does.
Yes, I agree. Again, delivery is very important, and orally disintegrated tablet, you cannot create anything simpler than that. And comparing it with injections, even rare injections, but still much easier and much for a lot of patients, it's a big barrier injectable. So they will be happy to try oral medication for prevention.
Well, and now that Nurtec is available for prevention, does that remove a barrier for you? So you're saying typically for you, you would refer to neurology for maybe monoclonal, but 100%. This is something you might do.
Absolutely, and this is what I will definitely do, and that will decrease my referral pattern. Absolutely, because it's easy to prescribe. It's the same medication, and there is nothing to consider extra. So, yeah.
Fascinating.
For a patient who had acute experience with Ubrelvy, which also is a GPAN, a CGRP receptor antagonist, if they had a positive response to that product, would you be more comfortable switching them to Nurtec for prevention? Do you see that as being interchangeable, or is there enough of a difference between those two molecules that it really needs to be rimogepant prior to transitioning to preventive dosing?
I think that I would probably try off-label prevention for Ubrelvy.
Well, since you brought that up, what has been your clinical experience with using? I mean, I'll just say in our data, we see quite a bit of off-label preventive dosing of the GPANs. And actually, it was substantially higher among the PCPs who we surveyed just 2-3 weeks after the specialists. So, it shouldn't be anything market related. But we saw the vast majority of PCPs having some experience with their patients using the GPANs, dosing the GPANs preventively, and estimating a higher percent. And often saying, especially for Ubrelvy, that they would use samples to help support that more regular dosing. Is that something that Dr. Story, Dr. Bilik, that you've had experience with in your practices?
I can't say that I have, no.
I do. I have plenty of samples of Ubrelvy, and it's the company had been excellent in supplying them, so that I have at least, ballpark, I think maybe about 20 tablets in my office at least.
So with the approval of Nurtec for preventive, does that increase kind of your comfort and your willingness to continue to use a Ubrelvy for the appropriate patient with preventive dosing?
I'm sorry, can you repeat the question?
Sure. With the approval now of Nurtec for preventive treatment, does that increase your willingness or your comfort? I mean, it sounds like you're pretty comfortable already, but with recommending to your patients dosing Ubrelvy
For prevention?
Yeah.
I would not be 100% comfortable, but I may recommend in certain instances patients to try.
So I think a related theme there for me is that one of the most common prescription patterns that I use is home therapy for status migrainosis, so that we have patients who have had, frequently have severe attacks that go on for days or weeks, sometimes patients who appear to have had one continuous migraine for months or years, and that my standard therapy there has been something like a combination of a long-acting oral triptan like Frova or Neurotriptan with an NSAID and a dopamine blocking agent like Reglan twice a day for 5 or 6 days. And that has a really good likelihood of inducing remission of at least that attack. So what's started to happen in the last year or so is that headache people have started to try the similar thing with Nurtec, maybe Ubrelvy, as a kind of induction therapy. Take this once or twice a day, depending on the drug. Do that for a week. Maybe that will flip you or break it or whatever you want to call that. And I think now that we have approval for Nurtec for prevention and presumably will have access to higher numbers of tablets per month, I'm guessing that I will certainly be doing something like that more often. Take this for 5 or 6 days in a row, then switch to every other day dosing, see how you do, something like that.
Oh, thank you for sharing that. That'll be very helpful.
Yeah.
Yeah, let me know how that goes.
We're getting some good recommendations within the group. Realizing we're getting close to time, I did just want to ask 2 more questions. One to finish up this current topic. Do you think that with this broader label of Nurtec will impact your selection of the GPAD for acute treatment? Will you be more likely to reach for Nurtec because of the potential of expanding it to preventive dosing? Or do you still have, kind of your ideal patient types that you're going to continue to use Ubrelvy? Kind of how will that dynamic change for acute treatment?
Dr. Story?
I think that we will be using it more for acute and maintenance treatment.
So
it still has the indication of people that have the baseline of more than 15 headache days per month.
Right, different animal.
Mm-hmm.
But it sounds like because of its expanded prescribing, of its expanded indications, that you might be starting with Nurtec more often in the future than you were, as opposed to Ubrelvy?
Yeah, we've been kind of Nurtec fans anyway.
Fair enough. Dr. Bilik?
Yeah, I think it's a fair assumption. I think considering the extra indication is always good. And if we'll have a good support from the company in terms of samples, that would be even better.
Yeah, I have to say, so far for me, the main distinguishing feature there has been the option to redose Ubrelvy, that you can use 2 different doses, that you can redose at 2 hours. So for patients who have a lot of variability in the severity of their attacks, they get some mild headaches, they get some terrible migraines, the option to switch up their dosing for a given attack has been a plus, as opposed to try Nurtec, and then if that doesn't work, we have to try something else. So I think that will start to sort of work itself out in terms of the type of patient you're treating, and whether once daily dosing is the right option for somebody with fairly stable headache types, or I'm not quite sure. But when flexibility is a useful feature, I think it's great that we have that.
That's a great point.
Mm-hmm.
All right, just one last question. So if you had, your way, and you could ask for any clinical data within migraine that you most want to have, what would that be? What clinical trial would you most like to see a pharmaceutical company undertake that would really benefit your treatment and management of your migraine patients? We'll start with Dr. Bilik.
I would probably ask for the study of comparative study of triptans and GPads.
Okay.
I think it had never been done in large scope, and we still don't know. And we see what's going on with the patients, but it would be nice to confirm this is the efficacy of these two groups. What is better?
Yeah, and I mean, would that impact more your prescribing patterns, or do you think it would make it easier from a payer point of view of being able to prescribe with that?
Probably will shift prescribing pattern of every practitioner to certain direction, but I don't know which one. That's why it probably wasn't done. but it may significantly impact prescribing pattern. I'm sure.
Well, Novartis did the comparative trial of Aimovig with topiramate, and that definitely is something I hear a lot during our research that made an impact. So, I mean, if you have the guts to do it, it can really resonate with the physicians. Dr. Story, how about you?
I would like to see safety data in pregnancy and lactation, since so many of our migraine patients are young women.
Which
molecule? I know that's a difficult bar to clear. It's hard to do an ethical study.
Do you think that's more important for the monoclonals or the oral agents?
Probably, if you were having to pick, probably the oral agents, because they're going to be more popular.
Yeah, I agree. So I think those are both crucial things. I think, Dr. Bilik, one interesting question that relates to that I've thought about a lot lately is not just how do triptans compare to GPads acutely, like, pound for pound, what's the likelihood of relief, but if you prescribe either of those to a new patient today, what do they look like in a year? Because what we know from studies like the AMPP trial, a prospective cohort study, is that people who say, my acute therapy is awesome, I take it, I'm better in 2 hours, it doesn't come back, I feel totally in control, are very unlikely to progress in terms of migraine severity over a year, as opposed to people who say, it helps, they get worse. So given that, my impression is if you took people and gave them triptans or GPads and say, what do they look like a year later, that what we know now suggests the GPads will clearly outshine them. And that, I think, for you is, that kind of data would be essential.
Absolutely, yeah. But I love your confidence, but medicine is medicine. It's
right. Could be totally wrong. But that's at least something I think would be helpful to know. And Dr. Story, there's no question that we need safety data of that type. And then for someone like me, obviously, the big bugaboo is monoclonals plus Botox. We are doing this all the time. We want to be able to continue to do it. We want to be able to do it more. We have excellent preclinical data that shows that the mechanism of action is sufficiently different that they are actually therapies that work well together, that the synergy is meaningful, but it's still a huge uphill climb. And so we would really like to see somebody take that on and say, this is why it's worth doing.
Absolutely. Well, this was wonderful. Thank you so much for your time and sharing your perspectives. I'm excited to do this again because I just learned so much. I'm taking notes over here, but I hope you have a wonderful rest of your week. And Dr. Gottschalk, I will see you and your residence at our poster at the American Headache Society tomorrow. So that'll be great. So thank you very much.
Thank
you for the opportunity.
Absolutely.
Extremely valuable for me. It's great to meet you both, and feel free to contact me anytime if you have any thoughts or questions.
That's wonderful. Thank you so much, and nice to meet you.